Hi, everyone. This is Dr. Weaver, and I wanted to go ahead and create this voiceover so that we might continue our discussion regarding staffing and nursing care delivery models. So without further ado, let me go ahead and share. It seems to be working a whole lot better than before. So oh, yeah, that's what I was looking for. All right. So, as you all know, we will discuss um, this topic in class, and the voiceover actually starts on slide 18, I believe. Yeah, slide 18. And so just make sure um, when you come to class, or whether you come to class or not, just make sure you start at the beginning, of course, of the lecture or the material that I send you, the PowerPoints. Um, because you actually get more of a, I guess you can say, more commentary with this presentation before you get the commentary starting, from the first slide and on to slide 17. Anyway, you guys know what I mean. We've been doing this for a minute now. All right, so let me go ahead and increase my slideshow, and you should be able to see that. We're going to talk about a philosophy that is referred to as patient-centered care. Now, the Institute of Medicine, they actually defined what is patient-centered care. And it is defined as providing care that is respectful of, responsive to individual patient preferences, needs, and values, and ensuring that patient values guide all clinical decisions. All right. Now, one thing I will tell you is that this was not always the case. Um, that the part of this definition where it talks about individual patient preferences, needs, and values. There was a time where in healthcare, there was always this kind of paternalistic approach where we were the authority figure on healthcare, and whatever we say, um, the our patients had to basically follow uh, that directive, if you will. But of course, healthcare has been transformed or evolved over a period of time, and so now, not only in this class, but any of your other classes, your med surg classes, any of your healthcare delivery type of courses, this patient preferences, needs, and values is going to be a common theme because we want the patients to be involved in their care process, the patients and their families, actually, because you actually get better buy-in when patients are allowed to have choice in their health care. So just keep that in mind. These are some pretty strong buzzwords: patient preferences, needs, and values. Pretty strong buzzwords that I want you to keep at the forefront of your mind. Now, delivering patient-centered care means that nurses, physicians, and other healthcare professionals partner with patients and families in shared decision-making to ensure that healthcare decisions respect patients' wants, their needs, and also preferences. And also, patients have the education and support they need to make decisions about and participate in their own care. So we're going to be doing quite a bit of patient education. Again, as I said to you before, we typically use the what do you call it? The teach back approach, because we need to ensure that that the decisions that patients are making are well informed, and it is based on the reality of what is going on with them. All right. Now, to get patient-centered care means to support patients to live their best possible lives within their own unique experiences. This is not a one-size-fit-all. Now, patient-centered care is more of a philosophy of care than a typical care delivery model as discussed in the previous sections. However, because patient-centered care has become a core focus in today's healthcare organizations, it must be incorporated as an essential component of any nursing care delivery model. And as I said, these are some of the buzzwords that patient preferences and needs and values that you guys are going to continue to hear. These concepts principles are essentially threaded through all of your care delivery courses. All right. Continuing with patient-centered care, methods to engage patients, families, and significant others as partners in care. All right. So some of the things that we can do in order to ensure that patient-centered care is at the forefront. Include them in developing care plans and also discharge plans. Include them in change of shift or handoff reports. Um, some facilities will do walking rounds where both the nurse who is coming on and the nurse who is going off will actually do a handoff report in the presence of the patient and their family members. And this is good because um, things can be clarified, right? Any issues or concerns can be clarified. The patient is apprised to their care status and what have you. And family members, of course, they get their questions answered. Remember, as far as that discharge planning, it's good to have good support systems in place. And of course, the folks who are, or the family members, if they're going to participate or be involved in that discharge planning when the patient goes home and whatever their needs are, then they need to be in the know as well and not a burden. Sometimes sometimes they can come off that way, can be very needy, but they are part of the healthcare team, believe it or not. Provide them with the information and education needed to make informed decisions. And as I said, think about the teach back approach. Teach back does not mean that, all right, I tell you, let's say, for example, I tell you 10 words and then you repeat the 10 words back to me. That's not teach back. I give you 10 words, whatever that is, and then you tell me what that means to you. That's the teach back approach. And we use layman's terms, a language that patients and families can understand. All right. Establish family advisory councils to engage patients and families in decision making. And these are opportunities for family members and patients, of course, where they can offer some perspectives that we may not see as a healthcare or clinicians, if you will. Now, ARAC, or the Agency for Healthcare Research and Quality, recommends the SHARE approach to guide nurses and other healthcare professionals to support patients and families to make informed decisions regarding their healthcare. I want you guys to also focus on that shared decision making. The decisions are not coming one way, not from the clinicians, but we are sharing in this decision making. The healthcare clinician, patients, and families. It is a shared process. All right. Now, the healthcare team can use the following 5 steps. to, excuse me, to um, implement the share approach and ensure patients and families are fully engaged in their healthcare decision making. All right. They can, what we can do is seek the patient's participation, make sure the patients are participating in this shared decision making. All right. Help the patient explore and compare treatment options. People like to have choices, right? Don't need to overwhelm them with choices, but it is good to have other options, right? Assess the patient's values and preferences. Remember, I told you these are some buzzwords that will or are interwoven or threaded throughout the curriculum. All right. Reach a decision with the patient, right? You don't need to leave the patient on their own to make the decisions, but we want to reach this decision together. All right. Evaluate the patient's decision because sometimes if patients do not have all of the information to adequately make a safe decision, then we may have to do something a little different in that educate them more, take a little more time to educate them on the decisions that they're making. All right. This is especially the case when you're talking about not only people who we're more familiar with their cultures here in America, but people who are immigrants and what have you. Um, some decisions that they might make might involve things that they follow as far as culture, tradition, and so forth, their way of life. And it's some of the care, or rather the types of healthcare modalities that they use in their own cultures. Sometimes they can be dangerous. And um, there's a text, not a textbook, but there's a book that my students and what is it? Um, it is my nursing theories course that students have to, read the book, and then there's a discussion board surrounding, what they've read. But basically, and some of you probably heard of it. It goes something along the lines of something about these family members. They're from this. Or rather they're referred to as the Hmongs. And I may have that wrong, I'm sure, but basically, this family members or the husband and the wife, they have a child who falls down and has these seizures. And basically, the family members, because of their culture and what have you, they believe that it has to do with some kind of a spirit or evil spirit or what have you. And basically, they want the patient to be managed a certain way because perhaps they did not understand. I can't remember the ending of the book, if you will, but basically, it appears from what I can recollect, it's like they wanted to do away with the seizure therapy and incorporate some of their um, tradition or culture, into the care of this little boy. I believe it was a little boy. It could have been a little girl, but anyway, it doesn't matter. But anyway, but of course, in the Western part of the world, we have a different treatment approach, and so we just have to find safe ways of managing these types of patients because allowing this patient to go home under or the types of treatments that their culture calls for can be detrimental to the child. So we have to evaluate the patient's decision because you just never know what the barriers are to good decision making. Right. Another concept we discuss here is case management, or the definition of case management. Case management is a model of care in which the registered nurse, case manager, coordinates patient care with the goal of focusing attention on the quality, outcomes, and cost of care throughout an episode of illness, and also helping the patient move through a very complex continuum of care. All right. Just imagine, you come into the hospital and, you have all these health issues and whatnot, and, you're distressed, and our healthcare system is already complex enough. And so a lot can be lost in that whole process. And of course, the case managers, which came about probably the last 20 years or so, um, is actually a great role for nurses to, something you guys may want to think about as far as a job, career wise. It's not always at the bedside, but you can play the role of a case manager, and their job is to ensure that that patient has a safe journey throughout that continuum of care. Now, case managers may be employed by health insurance companies, your Aetnas and your what is it? It used to be Aetna. It's CVS, CVS something. I think I have them for insurance, but anyway. So any of the healthcare companies, sometimes they also stand alone care management or case management organizations that manages the care of patients, kind of like I believe they subcontract out the work to this group of nurses that can truly help to manage really complex cases. Now, as I said, they can be hired by health insurance companies to guide the care for health plan members. All right, these are members that belongs to a health insurance third party payers, and so the case managers work for them, and they may also be employed by hospitals to coordinate individual patients' care throughout the course of illness. And we'll get more into the different things that they do. Actually, you can see here where it talks about there's a collaborative approach to provide and coordinate healthcare services, identify and facilitate options and services for meeting health needs. And this is done in a rather cost-effective approach. Decrease fragmentation and duplication of care. The case manager, in looking at where the patient is and where they need to go, can ensure that the left hand and the right hand knows what's going on, and that there's no duplication, because duplication means more or more costly care. And so they can streamline the entire approach. Enhance quality, cost-effective clinical outcomes. And this is what it's actually all about. We want to improve quality, right? But in the most cost-effective approach possible. All right. Now, hospital nurse case managers, they manage a caseload of patients from pre-admission or before they come to the hospital, or the onset of illness, something that brings them to the hospital, all the way to discharge, all right, or a resolution of the illness itself. Now, although case managers generally do not perform direct care duties, they assume a planning and evaluative role, and collaborate with the interprofessional healthcare team to ensure that goals are met, quality is maintained, and progress toward discharge is made. All right. Remember, discharge planning begins day one, typically, right? Typically for your acute care admissions, right? And these group of nurses they are there from start to finish, ensuring that there's a smooth transition. All the resources are incorporated into the patient's care and what have you, and that the patient will have a safe discharge. That essentially the discharge goes off without a hitch, right? Um, and so this is so that discharges are not delayed, and also that if the patients are discharged to a safe location, whether that be a home with home care or skilled nursing facility, that it is a safe a discharge, and that they won't turn around and have to come back to the hospital, right? Because we're being proactive, and we're anticipating the case manager, that is, and making sure that, again, the discharge is safe. Right. So an example, the nurse case manager coordinates arrangements to move the patient from the acute care setting to a rehabilitation, to a home health, to independent living, as determined by whatever the patient's needs are. The case manager is there to help in that safe and timely transition, right? By the way, there is a certification that there's a test actually that one can take. In fact, an old a friend of mine, she just passed hers. Um, and there's a lot of opportunities if you can get these types of certifications, because again, we have a very complex system, and you need these folks in place to help to help navigate through such a complex system. So case management and other nursing care delivery models. So nursing case management in a healthcare facility supplements nursing care and does not take the place of the nursing care delivery model in place to provide, direct patient care. So, for example, if a hospital's medical surgical unit uses a team nursing approach to patient care, a system of case management might also be in place to assist with coordinating the patient's total care through discharge. Now, case management is not needed for every patient in a healthcare facility, and generally is reserved for chronically ill, seriously ill or injured, and long-term high cost, and that's the key, high cost patients. So what a case manager might do is, say if the physician or the nurse extender writes an order for a case management assessment, the case management will come look at at a particular case and determine whether or not their services are needed. All right. So there are some patients, they will, they will um, uh, process progress rather through the care delivery system relatively easily, and they'll be discharged and they're independent, or they have great support systems. So they really don't need um, that kind of a step-by-step approach from the case manager. So, but otherwise, those who do need case management services, um, there's been some really positive outcomes, due to their ability to help these patients transition throughout the system. As far as the newer models of case management, so healthcare reform is guiding health care to move from expensive acute care settings to less costly community and also home settings. So I mentioned to you all, which you probably wouldn't remember this, but I mentioned to you guys a while back that the acute care setting is actually um, the most expensive setting to care for patients. Remember, there was some statistics that talked about 50, maybe 59% nurses work in the acute care setting. But it is a very expensive place to care for people, which is one of the big reasons why patients they come and then they're gone, right? They're admitted and then they're discharged very quickly. They don't like to keep them there. The moment that patient is stabilized and they can get that patient into the next lower level of care. And next lower level of care can be a nursing home, excuse me, not a nursing home, a skilled nursing facility, a rehabilitation center, or even home, because it is less expensive. And then, of course, the care can continue. Continue as in the patient may require dressing changes, may require IV antibiotics, or whatever the service might be that can be managed in that lower level of care. And so this is all about this healthcare reform, trying to cut costs. As you can probably imagine, many years ago, we took advantage of that system. We had patients in the hospitals that should not have been in the hospital for the length of time that they were, and they could have been discharged in a more safer environment and what have you. And so they took advantage of it, and of course, healthcare reform was instituted to try to curb these costs. And keep in mind that when the cost of care increases like that, then the insurance companies, they will pass on those expenses to consumers, and so we have these high premiums that we, of course, have to pay. Now, along with this movement to lower to a lower cost care setting, there is a growing need to improve care for individuals with multiple chronic diseases who may also struggle with issues related to social determinants of health. All right. Remember those social determinants of health. These patients may not have insurance. All right. These patients might live in a unsafe environment, whatever the social issues are that could or is impacting their ability to be healthy. All right. You have your lack of safe housing. You have nutritious foods that they may be lacking, and other social supports that enable good self-care. They may not have access to. So the new care models with a foundation in case management are emerging to help better support these types of individuals who are impacted. Now, the first such model is the use of what is called patient navigators. All right. This was first conceptualized in those receiving cancer treatment. Um, Patient navigators help patients maneuver through this maze of medical appointments, treatments and procedures, insurance and payment systems, patient support services, educational resources, and multiple other components of the healthcare system. And just by me enumerating those particular items, it should at least make you to understand how complex this system is. And to have someone who is truly savvy, who understands this complex environment or system to help patiently help you navigate through this system can truly improve patient outcomes. Now, the use of patient navigators has been expanded to better manage patients with chronic diseases, for example, diabetes and heart failure, and to coordinate support from the interprofessional team, the pharmacists, the dietitians, and the physicians, and the nurses, and so forth. Um, And so the social work is a big help, right? Now, patient navigator responsibilities in conjunction with the interprofessional team include helping patients access resources such as the community food bank, free medication programs. As I said, some of these patients may not have insurance, right? And so they cannot obtain their prescriptions. And if they can't, let's say a heart failure patient cannot obtain their diuretics, right? Go home, begin to fill up again as far as fluids, and then they're right back into the hospital again. And so these patient navigators are in place because they can tap into some of those resources. For example, free medication programs to get the script for the patient so that they might take their medications and, of course, remain safely in the community. Also, they assist with making home visits to assess the home environment. Sometimes these patients, they live in some pretty unsafe environments, possibly even throw rugs on the floor, that if you have someone with limited mobility, they might easily fall and injure themselves and end up right back in the hospital. And so home visit assessments are integral to this whole process. All right. Also, implications for chronic disease management and communicating with other members of the healthcare team to support appropriate care decisions. It is a collaborative, interdisciplinary approach that is employed. Now, a second model, referred to as transitional care, has provided also a new role for the RN. See, this is what I'm saying. Um, Let me just say that even if you guys say to yourselves, I just can't do that bedside thing, do it for a couple of years, get your experience, because there's so many different roles that you can take on. Again, this is one of the other new roles, not only case managers, but you have your transitional care managers and many others where you can still be a part of that whole caring process. Right. Now, as patients with, as far as this transition of care role, as patients with complex care needs move through different levels of the care, levels of care, and between multiple providers, communication may be rushed and also inadequate. And this, of course, can result in errors in medications, lack of follow through on key referrals that might be needed, duplicate testing, inconsistent patient monitoring, and overall poorer patient outcomes. All right. And so these folks are in place, the transitional care nurses, to reduce these hiccups, if you will, these issues that can adversely impact our patients. So, of course, the healthcare system is recognizing the value of nurses to facilitate that safe and effective transition for the chronically ill patients. Hey, you guys are getting a lot of education surrounding this. So, who else would be better, right? Take a look at box 21 1. Um, and it lists some of the typical responsibilities of a transitional care nurse. Now, nurse case managers, patient navigators, transitional care nurses all have similar goals. And what is that? That is to work throughout this complex maze of healthcare entities to ensure that patients receive the best care possible at the lowest cost in the most appropriate setting with the resources they need to be successful in managing their own care to the extent possible. And that's what it's all about. All right. Everybody does not need to be in the acute care setting. Some people can be adequately and appropriately taken care of in the home setting. Say if all they're getting is IV antibiotics, that can be done in the home setting. It does not need to be done in an acute care setting where the cost of care is astronomical. Let's also talk about some clinical pathways. We'll get into what these actually are. Um, a memory, of course, comes to mind when I think about clinical pathways. And what you will get, what you will come to understand about clinical pathways is they're basically like pre-orders, right? Um, Orders that are typically written for certain patient populations, right? Or certain people, or rather, I should say, patients who come in with certain disease processes. For example, you have some clinical pathways for pneumonia, for heart failure, for COPD, and so forth and so on. And basically, they're rather standardized, right? And I can remember we had some physicians in the past. They were very much against these clinical pathways. I think we have this one physician. Can't remember. Excuse me, can't remember what that doctor's name was at the moment. Anyway, he was kind of mean, but he called it cookbook medicine, right? What I liked about the pathways, though, is that you can individualize it to the patient, but they just I wish I had one that I can actually show you. Possibly see if I can show you in class if I can find one. But basically, say if you got a patient who comes in with heart failure, this clinical pathway, it looked like a order sheets. Of course, you're on computers now, so in the system, it should have all the relevant treatment modalities related to those types of patients. And all a physician has to do is go through just clicking through, right? And that way you don't miss anything. And of course, the patient is receiving timely care and a treatment, and they can transition through that acute care process to a discharge safely and what have you. So I don't, it's just hard to get people to change. And this physician, he just did not like the clinical pathways. So clinical pathways are also called the critical paths or practice protocols or patient care protocols and care maps, right? Um, um, and they are clinical management plans that specify major patient care activities. Also interprofessional interventions, what those are. It's all listed on these clinical pathways. And desired outcomes within a specified time for a particular diagnosis or health condition. And remember, I said that before reading this. But basically, um, and what they probably do is they look at those disease processes that are more complex, that they are more expensive, and they have these clinical pathways to try to reduce the cost of care. Physicians are human, and sometimes they might miss things. And of course, with the clinical pathway, it has these kind of preset orders that it can help them to order the right things at the right times, if you will. Kind of like a something that prompts you, if that makes sense. Now, the advantage of the clinical pathway is that it provides a means of standardizing care for patients with similar diagnosis and defines key processes and patient goals in the day-to-day management of care. And I believe, though, from what I can remember, you may have like day one, this is all that is required. Day two, this is all that is required. Day three, and so forth and so on. And so you're basically trying to keep the patient on target with their care. Now, a similar but different term, clinical practice guidelines, um, guide broader decision making and focus on the decisions to perform a procedure or service. Now, I'm not sure if you guys have had any, excuse me, any courses where you discussed clinical practice guidelines. My evidence or my research translation students, they actually have an activity where they have to find a clinical practice guideline related to any particular health issue. And so, but basically, clinical practice guidelines. So they have this group of this panel of specialists of healthcare. It's like a healthcare team. They convene a meeting, and so they look at let's say, for example, hypertension. So they look at a lot or quite a bit of systematic reviews. Remember, systematic reviews are level one evidence in that hierarchy of evidence. And so they look at these systematic reviews, right? And they develop these practice guidelines or recommendations. It tells or informs clinicians in the clinical setting, based on all this evidence, this is the best treatment approach. Of course, you individualize it to any given patient, but basically they just make these recommendations to help us well, help those who are clinical, to make safe, evidence-based decisions, right? So the clinical practice guidelines are recommendations that are based on or supported by systematic reviews. All right. So another example would be a CPG would be used to determine whether, on the basis of a patient's specific cancer diagnosis, age, and other comorbidities, a patient diagnosed with prostate cancer should undergo radiation treatment. I mean, that may be a part of the clinical practice guideline and the research that it has employed. Now, the clinical pathway would guide the care provided to a patient currently undergoing radiation therapy. This is what this clinical pathway is what would be, well, these days in a system, right, an electronic system where they would follow a certain treatment regimen or protocol. Now, clinical pathways are usually developed within the healthcare facility, right? They probably have a panel of physicians who get together and they develop these pathways. And they, of course, are based on broader CPGs or the clinical practice guidelines. Now, because clinical pathways dictate the type and amount of care given, they have financial implications for the healthcare facilities. And so, they're going to try to streamline the type of care these patients are getting. But, as long as it's safe and it's efficient and it's evidence-based, then it can only, it removes a lot of waste, inefficiencies, delays, and so forth, and incorporates that which is more efficient and timely. All right. Now, in essence, the clinical pathway can be viewed as a roadmap the patient and the healthcare team should follow to guide the patient's care management and also recovery. Clinical pathways were developed in response to the need to identify quality, cost-effective care plans in order to reduce the patient's length of stay in the hospital. And that's essentially what it all goes back to money, right? But we shouldn't be wasteful. You guys know that. You shouldn't be wasteful. So. But maybe when you guys go to clinical, maybe ask one of the nurses to show you a clinical, to show you a clinical pathway. Now, there are certain components of the clinical pathway. The clinical components of the clinical pathway. So this this document, I guess I would probably refer to it. It includes the physical assessment guidelines, what should be noted for any given diagnosis or health issue. It has an area that addresses laboratory and diagnostic tests that are appropriate for that disease process. What are the usual medications, right? And procedures that are required. Safety and self-care activities. It addresses nutrition, right? Patient and family education, which we need, that we know that they need. There's also discharge planning and also milestones the patient should achieve through the progression of care. It helps us to determine if the patient is progressing based on, day one, day two, day three. This is where they should be. Are they there? Yes. Are they there? No. Of course, if the answer is no, then we perhaps have to go back and figure out why. Now, many clinical pathways also address triggers, which are events that I identify potential or actual variations in the patient's response to the planned interventions. Sometimes people don't follow a linear kind of a progression. There are other issues that might come into play, right? That we need to consider, and these are referred to as triggers, and how to address them if need be. With heart failure, I'm guessing that one of the triggers might be pulmonary edema, right? Maybe the nurse, was concerned about a patient's urine output being low, and contact the doctor, and the doctor said, go ahead and give a liter of IV fluids, and the nurse infused the IV fluids too quickly, threw the patient into pulmonary edema. And of course, this could be one of those triggers that is addressed, which typically involves a certain treatment protocol to manage, because it is a medical emergency. Now, common uses for clinical pathways in acute care settings are for the treatment of, for example, community-acquired pneumonia. So there's a clinical pathway for that one. A common surgical procedure such as total hip or knee replacements, for strokes or TIAs or transient ischemic attacks. We refer to them as TIAs. I believe there's one for heart failure. They don't list it here, but I believe there is one for heart failure as well. And so there's a variety of disease processes that, we're just trying to curb cost. All right. Examples of different healthcare settings are requiring different models. So your book talks about the different settings in the hospital. It could be the ED, the operating room, any particular unit, an ICU, or what have you. And there's certain models that we will discuss in class that are appropriate for these particular areas. So, for example, emergency departments use what is referred to as the functional nursing care model, because emphasis is on efficient assessment and immediate treatment. It's an ED, right? So this type of model is appropriate. You also have team nursing. Team nursing frequently used in a medical surgical unit. This type of model is appropriate for the med-surg unit. The total patient care is common in critical care units. Typically, you have one nurse taking care of two patients who are critical, and they have to assume the care, the total care of that patient. You may have a tech here and there that might help you with baths and may run and get certain items for you, but by and large, you are doing the majority of that work, and it can be quite a bit. The home healthcare agencies may use primary nursing, where they have, someone who's in charge of the care of the patient, and they have these different subordinates, if you will, or unlicensed assistant personnel beneath them who carries out certain tasks. But again, we'll get into what these different models are in class. Right. Now, the organizational structure, patient needs, and staff availability influence which delivery system will be used as well. All right. Now, in long-term care settings, such as nursing homes, skilled nursing, facilities, rehabilitation settings, patients remain in the care setting for an extended period of time. So therefore, the care delivery models may be structured differently, right, from those in the acute setting. You wouldn't use a total patient care model in these types of patients because you're going to need the unlicensed assistant personnel along with everyone else in this type of, uh, the type of care that the patient will require. Now, because of its, in this particular case, because of its economy and efficiency, functional nursing, which is a nursing care model, may be used for daily care tasks, whereas a form of primary care nursing is used for assessment, care planning, and also evaluation. Now, the home health care agencies often use a variation of the primary care model. Although in home care, the RN does not provide 24-hour care. I mean, that would be very expensive, right? He or she is responsible for the patient's needs for a 24-hour period and will coordinate intermittent care provided by others, including the home health care aide, the therapist, respiratory therapist, maybe the physical therapist, occupational therapist, and I think I may have said speech therapist, but anyway, so you have an RN who's in charge of that patient for 24 hours, but they're more remote than anything. But you're sending in these different care providers to perform certain services, so you're more or less delegating certain tasks, especially to the home care aide. Now, in the home care setting, the RN may also function in the role of case manager for his or her assigned patients. And so they're looking at that patient, their needs and anticipating their needs and making sure they're putting the right resources in place, helping the patient navigate through this complex system and what have you, so that, again, the patient outcomes will be desirable. Now, in every care setting, nurses should carefully evaluate the nursing care delivery model in order to ensure safe, efficient, and effective patient care. And so, and hopefully, the type of model being used is appropriate, of course. Evaluation of nursing care delivery models. So, in the evaluation of any care delivery model, there are some questions that you might ask in order to determine if it is the appropriate type of model for a given setting. Is patient safety ensured while optimal patient satisfaction and patient outcomes are achieved in a timely and cost-effective manner? Right? Does that exist as we look at the care delivery model? Is patient-centered care being provided with significant involvement of the patient and his or her family or significant other? Another question to think about. Are nurses, physicians, and other healthcare team members satisfied with the safety and quality of care they are able to provide? And if not, someone needs to speak up. There's an issue in utilizing this particular or whatever given a care model that may not be safe for this particular patient needs. Does the system allow for implementation of the nursing process in a timely and efficient manner? You know how important the nursing process is. All right. And does the system facilitate communication amongst all members of the healthcare team? And if it doesn't, there's going to be a major problem, as you all well know. So those questions will help you to determine if the delivery care model is apropos for given patient groups. The future, evolving nursing care delivery models. So because acute care settings now admit only the most serious, ill, or injured individuals with a focus on stabilization and transition, the traditional models of nursing care may no longer apply, right? All those different models that we would have or that we will discuss in class on Friday, they are probably not as appropriate. Perhaps, and depending on what's on a given unit at the time. For example, during COVID, these delivery models would be more appropriate. But in ordinary times when patients are in and out of the hospital, and with all the different changes in the healthcare delivery system, keep an open mind that new care delivery models are going to come out and will be incorporated because they will be more appropriate for the circumstances and the times that are the reality of where we are today. Now, in the past, nurses provided care on the basis of comprehensive knowledge of the patient's needs, which were learned by caring for the patient over an extended period of time. Now, nurses may have an entirely new group of patients to care for every shift, or even more than once during a shift. I mean, the transition through the acute care setting is so fast that so you leave in the morning. You did your 12-hour shift, and then you come back that night. You may have a total different group of patients because again, we're trying to discharge them very quickly, safely, hopefully, but we're discharging them so quickly. Even if you are working on it within your 12-hour shift, patients are going home or they're transitioning to other lower level care settings and what have you. And because of that, you may have an entirely different group of patients. And it's really difficult to get a comprehensive knowledge of patients who are in and out so quickly. This may not be so much the case in a critical care unit, of course, because if patients are admitted to the critical care unit, they may be in a unit for at least maybe 3 to maybe 10 days, maybe more. But some of these other units, patients they come and go, and it's just really difficult to get a comprehensive knowledge of what their needs are, because again, they come and then they go. Now, identifying effective models of care to support the rapid transition of patients from one setting to another will be a continuing challenge for nurses and healthcare organizations. And so you guys may someday be on the forefront of that. We need nursing theorists, but we also need those who can think about the different care delivery models that that will be more appropriate for our reality today. Now, relationship-based care must also be considered part of the care delivery model in high-tech, fast-paced environments where nurses struggle to provide care that is consistent with nursing values of compassion, for caring, as well as healing. So therapeutic relationships to promote optimal health for our patients and communities are the essence of nursing practice and must be accepted as a primary responsibility of every RN. So it doesn't matter, what the technology is and all the other changes that we're dealing with. We need to keep therapeutic relationships to the forefront. Because this is the essence of what we do. Now, the future is here with new and innovative models of care emerging to address the challenges of today's complex healthcare environment. And so we will certainly need more updated models to help us or help our patients navigate through this ever evolving system. I think that is about it. Take a look at the, I won't read this whole list to you. Let's see. don't think there's anything difficult here. See, the way nursing care is delivered is changing dramatically, and new models of care are emerging. So we talked about that. Unprecedented stress placed on hospitals to care for large numbers of critical patients suffering from COVID. So again, with these types of patients, the total patient care, which is a care delivery model, would have been apropos. These patients were in an ICU, of course, and they require total patient care. So that's a model that would be appropriate depending on the circumstances, and that was a circumstance, as you all know. Fast-paced patient turnover in acute care settings. The rapid discharge and admission cycle is now referred to as churning. I never knew about that term, but yeah, they come in and they go. Many years ago, and I guess you guys can probably say, thank God we don't have to do that. But we used to have to go to the hospital. Say if we're going to do a clinical tomorrow. Let's say tomorrow is Wednesday. So um, Tuesday we would have to go to the hospital, get the patient's chart that we were going to be taking care of, and we would create our care plan and all that involves, right? And we can pretty much rest assured that even though we document all that information, that the next day when we come back with our clinical group, that patient will still be there. That's not the case now. I mean, you can develop all this information, right? To create this big care plan, and then come back and your patient is gone, right? So they no longer do that anymore, which is again, we have to change with this evolving situation in healthcare. We have to adjust and adapt, right? Social determinants of health recognized as playing a strong role in an individual's overall health. And you guys, I'm sure you've learned quite a bit about the social determinants, those social issues that cause people to have not the best health, right? So consider that in terms of the type of delivery models that would be appropriate. Strong focus on patient satisfaction, safety, and outcomes of care. Consumer demands for instant access to care and information, and need to engage patients and families to become active partners, rather, to make informed decisions and address their own health care needs. And this is what I talked about, the shared decision making, and considering that the patient values, preferences, and so forth and so on. And so that's about it, folks. This is just over an hour, and I will conclude at this time. Thank you. Stop sharing. And stop recording.